All right, so this part 2 lecture is going to talk about the last two disorders, Hirschsprung's, which is a motility disorder, and appendicitis, which is inflammatory, as well as a quick discussion on cleft lip and palate and failure to thrive. Hirschsprung's disease is a congenital disorder of the colon in which certain nerve cells, which are known as ganglion cells, are absent from the nervous region of the abdomen responsible for moving food in the intestine. So with an absence of these ganglion cells, this results in a lack of coordination of peristalsis, which is that muscle movement that pushes food around, which in turn decreases the internal sphincter's ability to relax. So normally stool bolus will enter the rectum, which then relaxes and releases, but here it actually cannot. So this lack of motility causes an obstruction. The aganglionic segment affected is typically the rectum and some portion of the distal colon. Some cases can involve the entire colon and part of the small intestine as well, but that is more rare. The more severe the condition, the earlier it's going to be diagnosed. So don't worry about memorizing this list. I just want you to be aware of these clinical manifestations, specifically failure to pass meconium within 48 hours after birth in an infant or newborn, constipation as they get older, and some failure to thrive, and then these ribbon-like foul-smelling stools with potentially a palpable fecal mass because things are obstructed in there and you have a blockage. And so when something is blocked in the intestine and it's seeping around it and it's trying to get out, you're going to have this misshapen stool and it's going to smell pretty bad because it's been marinating in there for a while, right? And here they are bolded for your reference, okay? So this is all really just related to that lack of movement in the GI system. So we diagnose Hirschsprung's with a rectal biopsy because we need to see the tissue under a microscope to note the absence of the ganglion cells. X-rays can show us megacolon, which is when that colon will distend, and an anorectal manometry exam will use like a little catheter to change pressure in the rectum to help see how that sphincter will respond, but neither of those are definitive. It's biopsy, biopsy, biopsy for Hirschsprung's, okay? They will move up the GI tract and kind of take little punch biopsies along the way until they find an area where those ganglion cells return, and then they know how much of that colon is affected. So then depending on the severity, they will surgically remove the bowel that is not meeting performance expectations. So if it's less severe, they can usually just do one surgery. They'll connect the plumbing and then the child is effectively cured. There's still a risk of complications, obviously, but it is a single step procedure. The alternative is we'll do 2 stages where they'll create a temporary ostomy to allow the bowel to rest, and then they'll go back in for what they call a pull-through procedure. They'll create a new rectum and they will close the ostomy. So for home care, we are focused on any post-op concerns like infection and then anything that would be related to bowel issues, right? Enterocolitis is a primary complication, so we would tell family to watch for that. Also monitoring for constipation in the rare case that all the affected intestine was maybe not removed. If the child's going to have a temporary ostomy, we're going to do teaching on stomach care and how to do bag changes and how to care for the skin. And following that, we also want to prevent diaper rash because if they've had a colostomy for a while, they haven't been having bowel movements the normal way. And so when they start up again, their skin may get irritated. All right, we're going to talk about appendicitis for a minute, mainly because it's really common in school-aged children. So appendicitis is an acute inflammation of the appendix where an obstruction leads to distension and sometimes a bacterial infection. So the common age that we see this is usually 10 to 19 in males. Some risk factors would include family history, a prior abdominal surgery, cystic fibrosis. If it's untreated, appendicitis can lead to necrosis, perforation, and peritonitis. So generally with appendicitis, discomfort will begin at the umbilicus and then it will move toward the lower right quadrant, which is also called McBurney's point. The pain tends to get worse with movement and it can include nausea, vomiting, and fever. We will diagnose appendicitis with a combination of a physical exam, some labs like a CBC and some electrolytes, and then a CT scan. Patients may be mildly dehydrated due to being nauseous and not eating all that much. A sudden improvement of pain would actually indicate perforation here and would require a follow-up. So appendectomies are the primary treatment. These are often done laparoscopically. We will give antibiotics pre and post-operatively to prevent infection in the abdomen. Pre-operatively, a right-sided semi-Fowler's position could be the most comfortable for these patients. And then in the post-op period, we are primarily focused on pain management, early ambulation to help get that gas out of the abdominal cavity that they use to inflate it for the laparoscopic procedure, and then monitor for signs and symptoms of infection. Diet here can be advanced as tolerated as long as bowel sounds are present. So recovery, if we have a perforation, would be more complex, and that can involve a JP drain or an NG tube to suction to continue to remove some of the gunk that's kind of in there. And then we are also going to give antibiotics for a longer period of time in order to treat that internal infection. Nope. All right, so cleft lip and palate. So this is another structural defect that you're going to see in the pediatric population, and this occurs when there is a failure of the maxillary and premaxillary processes to come together. This is usually between the 4th and 10th weeks of embryonic development. They can occur separately, but more often if a patient has a cleft lip, they will also have a cleft palate, because if you think about kind of how all of that is connected, it just kind of gets deeper and deeper the more severe it is. So while they do often appear together, they happen at different times during development. They can be separate. So the primary palate of the upper lip is developed in the 7th week of gestation, and then the fusion of that secondary palate, or the hard and soft, occurs between the 7th and 10th weeks. So you can also have either a unilateral or a bilateral cleft palate or cleft lip. And this can be an isolated anatomical change, or it can happen as part of a syndrome where cleft lip and palate are associated. We'll diagnose this by assessment. You can see it, right? When an infant is born, the lip is obviously more apparent, but a cleft palate would require a thorough assessment of the oral cavity in order to identify. Management is surgical repair. The infant, if they have both a lip and a palate, they will often do the lip first, usually before 6 months of age. And while it is not an absolute rule, they have a rule of 10 that they tend to follow with. This is like the child has to be 10 pounds and 10 weeks prior to doing the repair of the lip. And then the cleft palate repair is a little bit more complex because it's bone, right, as opposed to skin. And so it has the best outcomes if the infant is slightly older. So they will see that a little bit later in life. And ideally, we're doing both of these before significant speech development so that that is not affected. These patients with cleft palate will often need ear tubes to reduce the risk of chronic fluid in the middle ear, which can lead to hearing loss. So overall feeding is really what would present as the biggest challenge for these infants with these cleft lips and palates. It doesn't affect their ability to swallow, but the challenge is helping them create a vacuum-like sensation when sucking in order to be able to effectively feed. And then real quickly before we wrap up, I wanted to mention failure to thrive because this is a pretty common admission that we see on the pediatric floor. It's not specifically GI, it's more related to nutrition, but it has to do with ingestion and digestion. So we have it here. Usually it's diagnosed if a child is under the 5th percentile or has any unexplained loss. Typically, clinically, I see patients coming in that have a noted weight loss at like multiple doctor's appointments, or they're not gaining based on what they're expected to be gaining. So they get admitted basically for us to rule out an organic versus inorganic cause, to figure out if there's an underlying medical condition or if there is maybe a psychosocial factor. Some organic causes could be things like celiac disease, food intolerances, reflux, infections, even endocrine disorders. If we're looking at inorganic causes, then we are maybe looking at parents not waking the baby to feed, lack of education on nutrition, or neglect. Failure to thrive is a big deal because nutrition is such a large component of development. So these kids are at risk for developmental delays, stunted growth, and vitamin deficiencies. So figuring out the underlying cause and getting some weight gain occurring while they are in the hospital is a priority here. All right, that's going to wrap up GI. Have a great rest of your day.